Dr. Ken Landau. Thanks for watching. Let's talk about the metabolic syndrome. The metabolic syndrome, or syndrome X, or the insulin resistance syndrome, or the obesity syndrome, is a condition that puts you at high risk for a variety of metabolic abnormalities. And those metabolic abnormalities include having an increased incidence of atherosclerosis, so you have more heart attacks and stroke and angina and congestive heart failure and peripheral vascular disease and diabetes. You have a higher risk of all-cause mortality. These are the people who are more at risk for atrial fibrillation and fatty liver and gallstones and blood clotting disorders and deep vein thrombosis and obstructive sleep apnea and polycystic ovary disease and even Alzheimer's disease. And it's estimated that in the very near future that the metabolic syndrome is going to overtake cigarette smoking as the primary cause of heart disease in the United States. And if you have the metabolic syndrome, chances are overwhelming that you have a series of other biochemical abnormalities inside the body. So you have more of the fibrinogen and more of the other material in your system that makes you clot, like the plasminogen activator inhibitor, and more uric acid, and more of those other kind of chemicals that are associated with heart disease, like the C-reactive protein. Actually, the term itself, metabolic syndrome, comes from the 1970s, when it was thought that there were a series of conditions that seemed to be linked to atherosclerosis, but the whole concept really stems from the 1920s, when it was found that people who had collections of fat in the upper body, in other words, big waist rather than big hips, those people seemed to have a disproportionate risk of coronary vascular disease. But it all came down to Dr. Jerry Raven in 1988, and he described what he called Syndrome X, or the insulin resistance syndrome, where he emphasized that the insulin didn't work as well in people with this syndrome as it did in other people, and that led to a whole variety of metabolic changes. So what do we have? We have central obesity, or adiposity. So you would say that, geez, if you have a big waist, that's easy enough to make the diagnosis, and all you have to do is go and lose weight. Obviously very hard to do. But even people who have normal waist can have the insulin resistance syndrome. And we find that especially in people from India and Southeast Asia, and we find that in Central America. So it's a condition that centers on obesity. Now, before 1980, only about 15% of the people in the country were labeled as obese. But by 2015, that number had increased to about 40%. So there was a 25% increase, absolute increase. So more than a doubling, almost a tripling, of the obesity in the country, just in a period of about 35 years. And when you throw into there the number of people who are overweight, that's another 30%. So you can see we're talking about a condition that is extraordinarily frequent. The prevalence varies throughout the world, but in the United States, about 1 in 3 people have the metabolic syndrome. And it's a little more common in women than it is in men. To make the diagnosis of this condition, remember, it's a syndrome. It's not a disease by itself, but it's a syndrome. And to make the diagnosis, you have to have at least 3 of 5 factors. So you have to have a waistline here in the United States. If you're a man, more than 45 inches, if a woman, more than 40 inches. Triglyceride level, more than 150. High density lipoproteins, that's the good cholesterol. Less than 40 if you're a man, less than 50 if you're a woman. You have high blood pressure as an integral component, more than 130 over more than 85. And fasting blood sugar of more than 100, or having type 2 diabetes. Now, the most challenging part is, interestingly, determining what the waist circumference is, because it's not just the waist circumference itself, it's where the fat happens to be distributed in the waist. So we have some fat that's just under the surface of the skin. We call that subcutaneous fat, subcutaneous adipose tissue. But then we have other fat. And it's important to make the distinction. We have fat that's around your visceral organs, fat that's around your liver and your kidneys, and fat that's around your omentum, and fat that's around your other internal organs. And that is the fat that's strongly related to the insulin resistance and diabetes and congestive heart failure and cardiovascular disease. So it seems that you can't just look at a person, you can't just measure the waistline to determine if a person has the metabolic syndrome. And as a matter of fact, because of genetic variation, if we look at people from sub-Saharan Africa or the Middle East, in men, the definition of metabolic syndrome, waistline more than 43 inches, women more than 36 inches in Chinese individuals. Well, in males more than 41 inches, females more than a 36-inch waistline. In Japan, well, more than a 39-inch waistline for men, more than a 41-inch waistline for women. So it varies in different parts of the world. So the waist circumference, remember, doesn't differentiate the subcutaneous fat from the visceral fat. The only way we can do it right now at the present time is to get a CAT scan or an MRI. And why is such a big difference? Well, it seems that the adipose tissue that's in the viscera around the intestines and around the liver and around the kidneys and all, well, that delivers the material, the free fatty acids, directly to the liver. If we're talking about fat that's underneath the surface of the skin, the fatty acids are going to get into the systemic circulation, and it's going to take them a long time to get to the liver, and chances are they're going to be used elsewhere. Well, if we look at women, it seems that the risk factor for women tends to be more the waist circumference, but in men it's more the elevated blood sugar, elevated triglycerides, low level of HDL. Now, what are the clinical manifestations? There aren't any, other than we measure the waist circumference, check the blood pressure, check the blood sugar. If a person has elevated waistline, elevated blood pressure, then we ought to check for the rest of those components of this syndrome. Now, it's important to realize that the metabolic syndrome is not synonymous with obesity. So you have to have those other underlying components. You have to have the insulin resistance, and you have to have increased concentration of insulin, and it all is because of the visceral fat. So now we have to differentiate metabolically healthy obesity from metabolically unhealthy obesity. Obviously, the metabolically unhealthy obesity, that's the metabolic syndrome. But if we look at what the difference is in the people, is it the diet? No, not really. Is it physical activity? No, not really. Is it a genetic contribution? Yeah, but it may well mostly be some abnormality in the gut microbiome. The bacteria in your intestine might determine whether you're going to have the metabolic syndrome. And what determines what kind of bacteria you have in your gut? Well, interestingly, it just happens to be the kind of food that you eat. Now, when we talk about metabolically healthy obesity, the definition, there are more than 30 definitions actually for the condition, and most of them are not proper because they allow people who have one or two of the features of the metabolic syndrome to be included. So they're not really healthy, they're not really normal, they just seem to be transitioning from metabolically healthy obesity to the metabolically unhealthy obesity. But if we look at the people who are heavy, who don't have any cardiovascular issues, who don't have any of those risk factors, we find that it might make up as many as 7%. That means 93% or more of people who think they're healthy, even though they're heavy. Probably not the case. So one of the factors that we use to differentiate metabolically healthy obesity from the healthy from the unhealthy obesity is we look at the triglyceride level. And it seems that the differentiation level should probably be 95 rather than 150, because at 95, that's when those LDL, the bad cholesterol you hear so much about, well, it just so happens they're a different kind of bad cholesterol. And when you go over a triglyceride level of 95, you transition from a bad cholesterol that really isn't bad at all. We call it the buoyant LDL, or the buoyant bad cholesterol. Then over the level of triglycerides at 95, that's when you start developing the small dense lipoprotein. Those are the lipoproteins that cause atherosclerosis. Now, if we look at metabolically healthy obesity, it's more common in women, more common in younger individuals, more common in those individuals with a body mass index of less than 35. If it's over 35, you don't have metabolically healthy obesity. Well, the important thing to realize is that when we look at those people who have metabolically healthy versus metabolically unhealthy obesity, we can't differentiate the two on the basis of the energy intake or the change in the diet quality, and it doesn't seem that there's much change in physical activity. But it seems that there's that increased intrahepatic fat, and it's the intrahepatic fat, what we call steatosis, that seems to determine whether a person is going to have the insulin resistance, and if a person has the insulin resistance, you're on the road to the metabolically unhealthy obesity. Now, on top of all of that, here's the other issue. Well, we have inflammation, and it seems that obesity is associated with chronic low-grade, non-infectious type inflammation. So we have in the adipose cells, all around the adipose cells, we have immune cells, we have the macrophages. And the macrophages seem to be more frequent in people who have the metabolically unhealthy obesity than the people who have the metabolically healthy obesity. And specifically, the macrophages happen to be associated with some of the T lymphocytes. And we'll get back to that story in a moment, but that is extraordinarily critical because those are the cells that are going to put you at risk for developing all sorts of complications. So if we look at people who have the metabolic syndrome, those people are at 2 to 5-fold increased risk of developing diabetes. And if you have diabetes, chances are, type 2 diabetes, chances are probably around 70 or 80% that you also have the metabolic syndrome. And if you have the metabolic syndrome, your likelihood of dying from cardiovascular disease is about twice as great as it would be if you had all of the same components, but you didn't have the metabolic syndrome. Your likelihood of having a heart attack is about 3-fold greater, likelihood of having a stroke, 3-fold greater than if everything was the same, except you didn't have the metabolic syndrome. Now, we talk about HDL. HDL is very important because it's supposedly some mechanism to get the bad cholesterol out of the vessels, but really it determines to a large degree what kind of level of triglycerides you're going to have. And it seems that as the triglycerides go up, the good cholesterol goes down. So at any given level of LDL, you have a greater risk of having vascular disease, a heart attack, a stroke, than if you don't have the metabolic syndrome. So for any given level of LDL, let's say your LDL is 150. Well, if you have the metabolic syndrome, you're at greater risk for having a heart attack with that LDL, 150, than if you don't have the metabolic syndrome. So the LDL gets to be that bad form I mentioned. The small, dense LDL starts when your triglycerides get to be over about 95, and by the time they get to be over 180, you have a lot of small, dense LDL floating around. And remember, that's the more atherosclerotic type. That's going to lead to increased incidence of coronary artery disease. Now, we have another kind of a chemical. We have something called leptin, and leptin decreases your appetite, and it increases your energy expense, and it makes the insulin you have work even better. And it also may regulate the cardiac and the vascular function by producing more nitric oxide. But interestingly, in those people who have the metabolic syndrome, those people who are overweight, it appears that not only are they resistant to the action of insulin, they're resistant to the action of leptin. And that, again, puts them at higher risk. Now, the fat cells manufacture a chemical, and it's called adiponectin. And it seems that adiponectin is an anti-inflammatory substance. It's what we call a cytokine. Well, we like anti-inflammatory things because inflammation seems to be at the root of so many different kinds of diseases. Now, the adiponectin is produced exclusively by the fat cells, and it increases the insulin sensitivity. But unfortunately, as you develop more fat cells, it turns off the production of the adiponectin, and that puts you at greater risk. Well, we also have defects in the insulin action associated with the metabolic syndrome. So when a person has the metabolic syndrome, they can't turn off the production of the glucose by the different organs, especially the liver, also by the kidney. So we have a problem with multiple organs. And then we have hypertension. And hypertension is well known to be associated with insulin resistance. So under normal circumstances, insulin acts as what we call a vasodilator. It dilates the blood vessels, and it also increases sodium reabsorption from the kidney. Well, unfortunately, as you become insulin resistant, you lose the vasodilating effects. So we don't dilate the vessels the way you were supposed to, but you still reabsorb the salt. And when you reabsorb the salt or the sodium, then you develop the hypertension. And also, insulin has an activity to boost the sympathetic nervous system flow, and that seems to be associated also with developing the hypertension. So we have a balance between the vasodilating forces, like nitric oxide, and the vasoconstricting forces, like with the endothelin 1. And as a result of the metabolic syndrome, you start to decrease the blood flow to a variety of organs, which obviously may be a problem. And also it appears that some of the chemicals like angiotensin II seem to increase, and when they do that, then that can lead to hypertension. So now we have another issue. So we have a high level of blood sugar. Well, the blood sugar is bathing all of the organs in your body, and it happens to also bathe the intestinal epithelial cells, the cells that line the intestine. And when it does that, it leads to inflammation. And that inflammation in the intestine seems to be associated with a leaky gut. So now the cells that are normally supposed to have tight junctions and keep things from getting into your system that are bad for you, well, those cells become leaky, and all of a sudden we start developing some bacteria that are getting into the system, or some bacterial substances like lipopolysaccharide that are getting into the system. And now all of a sudden we have to sort of increase the definition or expand the definition of the metabolic syndrome, because now it's not just the chronic increase in the blood sugar, but it's also an increase in intestinal permeability and an increase in the risk of systemic infection. So now we have another issue. Insulin is an anti-lipolytic substance. So with insulin resistance, you don't stop the cells from breaking down the fat. And as the cells break down the fat, we get more fatty acids in the system. Well, that leads to an increase in the amount of inflammation. And first studies came out in 1993, and they linked the chronic low-grade inflammation to obesity and to insulin resistance. So now we have the fat cells that are interspersed with the macrophages and the T lymphocytes, and they're making the cytokines. Those are the cells, or the substances rather, that are associated with the inflammation. And now we have a problem with uric acid. Uric acid, well, it's elevated, and it reflects a defect in insulin working on the kidney. And that hyperuricemia, it's associated with hypertension. So the more uric acid you have in your body, the more likely you are to have hypertension. We know that if you treat pediatric population that has hypertension and elevated uric acid, bring the uric acid down, the high blood pressure goes away. And in addition to all of these other problems, it seems that the metabolic syndrome is associated with non-alcoholic fatty liver disease. That's the most common liver disease in the United States at the present time. It's associated with obstructive sleep apnea. So most of the people with obstructive sleep apnea tend to have central obesity. It's associated with polycystic ovary syndrome. It's associated with chronic kidney disease. And it's associated with abnormalities of the mucus layer of the gut. And now that's an interesting story, because it shifts in thickness, the amount of mucus. Well, if you consume a diet that has a lot of fiber, you're going to manufacture some short-chain fatty acids. And the short-chain fatty acids require a certain kind of bacteria. So not all bacteria manufacture them. Well, it seems that it's the fiber in your diet that leads to an increase in the concentration of short-chain fatty acids, most abundant of which are either acetate or propionate or butyrate. And those substances are very important because, among other things, they stimulate the feeling of satiety. They seem to be associated with the increased production of a hormone, peptide YY, that says, hey, I'm full, I'm not going to eat anymore. And it also associated with another chemical called GLP-1, glucagon-like peptide 1. And it seems that that's very important peptide for a number of reasons. We'll get back to that in a moment. But it seems that as we get our leaky gut, as we have some other kind of problems, as we have the wrong kind of bacteria, as we're eating more meat, then all of a sudden a chemical, phosphatidylcholine or choline, is changed by some of the bacteria in the gut through trimethylamine to trimethylamine N oxide. That's because of a change in the liver enzyme. So now all of a sudden we have the TMAO that'll get to be well known in the near future. Well, that chemical seems to be associated with an increased level of atherosclerosis. So a high-fat diet, a low-fat, low-fiber diet, well, that's associated with abnormal bacteria, or what we call dysbiosis. And unfortunately, when you have dysbiosis, you don't have enough of the GLP floating around. You don't have enough GLP floating around, then you don't maintain the intestinal function. You have the leaky gut. That's when you get the TMA or the TMAO to float around. That's when you get the endotoxins to float around. That's when you get some of those cytokines to float around. And all you have to do is, if you change your diet within 5 days of eating fruits and vegetables and grains and legumes, well, then you start to change the bacteria. But you don't get healthy instantly, of course. Now, in addition to everything else, if we look at the lining of the intestine, we find that it often has a type of T lymphocyte. That's a white blood cell. And white blood cells, different types. One type is a lymphocyte. Lymphocytes are very important in your immune system. We talk about the T lymphocytes because they're going to hopefully help prevent us from getting the COVID virus. That's going to be very important as far as the vaccines are concerned. So it's the hormones and the antibodies and the T lymphocytes. Well, we know that this GLP-1, that's going to have significant impact because it's going to help the pancreas make the insulin. It's going to be associated with improving cardiovascular outcome. It's going to have benefits to your metabolism. So all of that is critically important, and it has to do with the T lymphocytes. So if we look at the intraepithelial T lymphocytes, if we look at individuals who don't have those T lymphocytes present, the metabolism goes into overdrive. It doesn't make any difference what you eat, apparently. If we're talking about germ-free animals, we know that you can have a diet that's high in fat and high in sugar, and you're not going to develop any metabolic disease. You're not going to become obese. You're not going to become hypertensive. You're not going to develop the atherosclerosis. So it seems that the inflammatory cells and the concentration of those inflammatory cells inside the intestine has a lot to do with your metabolism, your body weight, the absorption of a variety of chemicals, the likelihood of your becoming insulin resistant, and it all flows together. So, what can we say about this syndrome? We can say the prevalence of the syndrome can decrease. So you can decrease the likelihood of developing the metabolic syndrome if you pay appropriate attention to your nutrition, which basically means don't follow any of the ads that you see on the television for the McDonald's and for the Burger King and for the Chuck E. Cheese or any of those other kind of fast foods. They're all quite toxic, unfortunately. So you need nutrition and diet. You need appropriate amount of physical activity. You have to lose weight. And maybe for some individuals, drug therapy might be appropriate, or surgical therapy, the stomach stapling or the gastric reduction procedures. Now, we can treat people with a variety of medicines. We can reduce your blood pressure, we can boost your HDL a little bit, we can reduce your triglycerides, and we can reduce your LDL. And all of that's important. No one argues with that. But unfortunately, it's putting a Band-Aid on the sore. What you want to do is you want to heal the sore. And to heal the sore, there are only two ways we can do it. It's diet and nutrition. Diet and nutrition. And if you do that, then you'll be much better off in the long run. Now, in the future, because we know that the intestinal bacteria are so important, one of the medical investigations that's now being pursued is consideration of fecal transplant. So if we put the good kind of bacteria into animal models, it seems we can correct the metabolic syndrome. Sometimes we can improve it with drugs like metformin, but at least for the present time, it's diet and exercise, and if you do that, you can avoid the metabolic syndrome, reduce your risk of a whole host of age-related conditions, and even premature conditions, because we know that those people who have the metabolic syndrome are susceptible to premature cardiovascular disease. So you have a heart attack when you're 45 or 35 years old. That's oftentimes related to the metabolic syndrome. So anyway, appreciate your time, appreciate your watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I'm Dr. Ken Landau. Thank you.